So welcome everyone to this week's Student Paramedic Society CPD talk. This week we've got John Talbot talking about cocaine and how it's related in paramedic practice. So John is a paramedic with Masters in Toxicology. He's the professional lead at the University of Hertfordshire and also works as an emergency care practitioner. He's also just published research in the paramedic use of toxidromes in recognizing poisons by different classes of drugs. So I personally been very excited for this talk. I'm sure it's going to be a great one. John's been helping the society out since before I was even here. So very much thank you for coming here. So just going to introduce the society and some points first before we begin. So just as always, any talks that we provide, always apply your own critical appraisal to any talks and before implementing anything into your own practice. So this is the webinar platform. So any participants attending this evening cannot be seen or heard. To ask a question, there is a Q&A chat box. It's separate from the chat. Yeah, there's a normal chat box, I believe. Use the Q&A one. And then any questions at the end, I'll direct to John. We might not be able to get through them all, but we'll get through as many as possible. And then at the end as well, when you sign out of the webinar, you will be given a feedback form. So if you could fill that in for us, we always welcome feedback on our CPD events. And also that will give you the option to request a certificate if you would like one for this event. So if you aren't a member already, there is the QR code. Please do sign up. It is completely free this year. A lot of our events are free and you don't have to be a member, but this will give you the option to come to our exclusive events and get the exclusive content. Access to the mentoring program, which is only available to members. And also it's just really helpful for us to be able to contact you all because we can then send out emails about events and things like that. Also to get information on future events, so any CPD, socials, things like that, here's our Twitter, Facebook and Instagram. So give one of those, at least one of those a follow, and that's probably the best way to get all our information and keep up to date with what we're doing. And whilst we're on social media, here is the East of England pre-hospital care hub. So that's the Faculty of Pre-Hospital Care, and they have different pages for different locations around the country. They're really useful. They're leading the way in pre-hospital emergency medicine, and they're really supporting student paramedics as well, or all students to be honest, and they are providing opportunities like elective placements for student paramedics at the moment. So definitely give them a follow and have a look at what they're doing because it's really good. So yeah, as I said, any questions, pop them in the box. That is all from us. So John, if you would like to share your screen, I will mute myself and the floor is yours.
Okay, thanks very much, Oliver. Hopefully everybody can hear me and hopefully everybody can see the screen in front of you. For those who probably don't know, this is Brian De Palma's 1983 epic Scarface. If there was ever a film that tried to depict cocaine in all of its various its ills, this is probably the one. Yeah, you can see this scene just slightly towards, just slightly before his demise at the end. I would point out, despite the content of this talk, he dies in a hail of bullets rather than from cocaine toxicity. But yeah, so welcome one and all to tonight's discussion, really. I'm going to talk for about 45 minutes to an hour about cocaine. I've called it Paramedic's Guide because I think to understand drugs the way that you understand them, which is probably different from the way that maybe a chemist or a pharmacist would approach a drug, is you actually have to understand drugs, particularly these types of drugs, in their kind of cultural context, really. Cocaine is a supreme drug. I mean, there's no getting away from it. There's probably no more efficient product for delivering pleasure. Not fast cars, not boats, not clothes. Nothing can give you on a dollar, pound, euro per gram basis the effect or that pure cocaine can give you, and or good quality cocaine. And by good quality cocaine, I'm not referring to a lot of the street level stuff that's had more cuts than a Japanese sushi chef's knife. So the really kind of high quality stuff, races into your brain, into your pleasure centers, and opens them wide. And I'll talk a little bit about that with you. And it keeps them wide open. If you look at experimental data from looking at cocaine, when they studied rats and given them, got a group of rats given half heroin, at 3 months, all the rats on heroin was still healthy, and the other group all on cocaine were all dead. That's because cocaine is a drug that people will take and animals will take almost to the exclusion of everything else, to exclusion of sex, food, water, almost anything. That is the power, I guess, of cocaine. So you've got to understand it in its kind of cultural context. It was quite slow in getting to Europe, and that's used typically to do, as I'll run through a bit of the history with you of cocaine, was getting the quality of leaves, coca leaves, to this to the shores of Europe, where they could be processed into cocaine. So that wasn't possible because of obviously the sailing ships at the time just weren't fast enough. So it took a while before cocaine really took off as a kind of drug of choice. It's been used by lots of pretty famous people, including Sigmund Freud and many others, and it's certainly a very popular recreational drug today, as we can see from drug data from around the world. So hopefully, just in setting the scene for you there, that I'll be able to give you a sort of greater insight into cocaine and what it's really all about. So in talking about cocaine in its kind of cultural context here, there are essentially there's two aspects to cocaine. And if anybody's ever been to any of my talks on, I did a couple of talks on hallucinogenic drugs. You have to understand those in their kind of cultural context. In different cultures, cocaine is a vastly different proposition to the one that you probably, if you look on the sort of party side of this picture, as it were, you can see a rather perhaps deranged looking chap there about to go for a couple of lines of cocaine there. A line for, although not an accurate measurement there, is probably contains about 20 to 50 milligrams of cocaine, or the alkaloid, the tropane alkaloid that is cocaine, that has such these such brilliant effects that people like. So on that side, you've got the more, I would say, the more European, if you like, and American, and very popular in Japan as well, cocaine. You've got that kind of view of it there on one side with a couple of lines, but on the other side, we've got the perhaps a slightly different context. We know that the coca leaf, and the coca is an Aymara word for, it means the tree, and we know that cocaine's been used by the native Indians of the Andes for probably about 3,000 years before Christ. So it has a very different, it plays a very different part in their culture. It can be used for altitude sickness, which it probably explains why it grows where it does. And I'll talk a little bit about that as we go. But yeah, it's these people are called coqueros, coca chewers, and they often walk around and they have like a big, they take a big wad of these coca leaves that you can see there. It's very different from the lines that you can see from the sort of westernized version, if you like. And they put them in their mouths, and they just use them as a stimulant to keep them kind of going for long periods of time. Okay, so as you can see, a very, very different, very different kind of cultural contexts, if you like. And if we just look at this is the coca leaf itself. As I said, the coca is an Aymara word that means the tree, and this is the Erythrocyllium coca. There are 250 species of it that exist principally in South America, around the Andean regions of Peru, Bolivia, and Colombia, some parts of Argentina and Mexico, Madagascar, the West Indies. Okay, and there are, as I say, there are about 250 species. In studies, there's been studies of about 29 of those species, and those studies showed that about 13 were cocaine positive. But actually, there's only a very few varieties, if you like, of the coca, the coca leaf that's actually good enough to produce cocaine in the quantities, if you like, that kind of make it worthwhile. So you've got Erythrocyllium coca, you've got Erythrocyllium ipadu, okay, which is a slightly different different quantity of cocaine in the leaf. And this one here, and this one is called Erythrocyllium novagrantesi, which was named after New Granada by the Spanish conquistadors. New Granada is what you would know as Colombia, and Colombia is now the producer of about 85 to 90% of the world's cocaine. So this is Erythrocyllium novagrantesi, or probably named, as I say, after New Granada. Now, this one here was probably the first species to be seen by white man, essentially Spanish conquistadors who came to South America. And they were pretty dismissive of it at first, but then they eventually realized that it had incredible properties to it. And there's evidence, archaeological evidence, of it being used in Peru going back about 2,500 years before Christ. So once the conquistadors kind of got hold of it, they tried to ship it all over the world, and eventually it became the cornerstone of the world drugs market. Now, if you take a leaf off this, about 99% of it is not cocaine. Okay, so the mean cocaine percentage of a leaf of one of these particular species is about 0.72%. Okay, so to try and put that into some sort of perspective for you, a reasonably good night out in central London, you'll need about 40 to 50 grams of these leaves, and that's probably about a jam jar full. So obviously that's not the way that people like to turn up at their party, club, whatever, with a jam jar full of these rather innocuous looking leaves. Okay, so that's just to talk a little bit about the various species, if you like, the various coca leaves that are out there. Now, I did say that culturally it's very different. Now, the bag on the left-hand side, as you look at your screen there, is called a chuspa. It's a pouch, and local indigenous Indians, they use these, they carry them around with them, they fill them full of coca leaves, and then what they'll do is they'll take a handful of these leaves and stuff them, if you like, for those that understand, who are doing a bit on drug delivery, it's delivered buccally, so they'll put them in the cheek of their in the corner of their mouth, in the buccal cavity there. But what's so ingenious is, if you look on the right hand side of this picture here, is you'll see a small substance in the middle here. This is called ellipta, and ellipta is an alkaline powder. Okay, and they make it by burning and drying out certain leaves, crushing up shells of shellfish into very, very fine powder, and mixing it all together. And what happens is that, just to let you know, that ellipta, if you put it on just directly into your mouth, would actually burn the tissues within. So not particularly a pleasant thing. So what they tend to do is they stuff a wad of these leaves in their mouth, and then they take a bit of this ellipta and they push it into the center of the leaves. And what that does is these ellipta is essentially an alkaline powder. Okay, and what that does is, as you know, that as I've said already, that cocaine is essentially a tropane alkaloid. That's how you get the effects from it. And what that does, this ellipta, is it raises the pH of your mouth. Now, if you, for those of you about to do pharmacology with me in the third year, and for those of you who've got it coming, I'll talk a bit more about this there in those kind of sessions. But essentially, if you can get the pH of your to a more alkaline content within your mouth, then obviously the alkalines that are in the alkaloids that are in these leaves will then be absorbed. So what they do is, by stuffing the leaves in and putting the ellipta in, they get a greater absorption of the contents, the alkaloid content of the coca leaf. So very, very smart, and they've known about this for about 2,500 years. So how they knew it remains to be seen, but they did know about it. And this is what I kind of always find very fascinating, really, about when studying and looking at drugs and looking at them in their history and their kind of cultural context. The leaf itself grows better at sea level. However, the contents increases as altitude increases. So between about 1,500 and 6,000 feet, about 457 to 1,830 meters. And also what we know, just as an aside, 100 grams of these leaves contain the recommended daily allowance of calcium, phosphorus, iron, and vitamin A, B2, and E. So you can see why it's used by tribes indigenous to these regions. You can see why it has a very, very different context than perhaps the one that we would recognize. Just to talk a little, you can see it's actually it's an industry in its own right. Clearly, these are not the big players of the drugs market. These are the people that, and you can see the bags of leaves there. If they could collect about 2 or 3 of those bags, they might get maybe about $6 or $7 US dollars. That is for that work, and it's actually quite hard work. And you can see here we've got a whole family out on the Andean hillsides here, collecting those leaves, ready to be used in cocaine processing. So how is it produced? Well, and as I said earlier, that the big problem with cocaine is that it was about getting the quality of leaves. By the time you put them in a ship's hull and ship them across to Europe, the quality of the leaves was really very poor, and it was really a very little value to you. And so the kind of breakthrough really was to actually be able to produce cocaine as a paste, and that's kind of become a tradition that's handed down by native tribes within, as I say, Peru, Bolivia, mostly Colombia. So as you can see here, it's very, very hard work. So often what they do is bandage their hands and fingers up like this, so they're able to strip large quantities of leaves off the trees and turn them eventually into cocaine. So yeah, you can see very, very hard work, tears at the fingers, but obviously they'll be using cocaine itself, which is a brilliant anesthetic in its own right. It's then taken back to their huts or wherever they choose to manufacture, and these obviously got quite a reasonable, factory going here. So he's using that sort of strimmer to chop all of those leaves up, and break them down to very, very small, much more readily usable leaves. So yeah, very good. He's got that sort of strimmer going there. And then what they do is they just cover it in a bit of cement. Okay. Yes, it probably makes you wonder why. And I do say, as you know, cocaine as a product, it needs no fancy packaging or labeling at all. And when you see how it's manufactured, you probably wonder what the attraction is. So yeah, and here it is. Those leaves are then covered in a bit of cement. There's some calcium hydroxide in there, And then these leaves will be put in big vats, okay? And then in those vats, they'll be mixed with kerosene and a bit of hydrochloric acid, okay? And what that does is it helps extract the alkaloid from it. And that's what you can see here. So you can see the guy there, the same hat. He's been able to fill these vats up with these leaves, cover a bit of cement. Those vats are filled with kerosene, a bit of hydrochloric acid, and then they're just mixed to allow the extraction of the alkaloid from that. And that what you get left with is this kind of paste here, called paster or pasta, pretty raw as it is there, and it's put in a press. And what they do is they keep squeeze to try and remove a lot of the kerosene and the water from it. So you get eventually, and then this product is then sieved and then heated up to get more of the water content out of it. So once you get this, it's about getting as much of the to this stage is about getting as much of the water and the kerosene out of it. And then finally, what you get left with is this kind of gooey product here. This is a coca paste. Okay, this is not worth an awful lot to the people who've made it. You need to make it in fairly bulky quantities, but eventually, yeah, this will be put onto a stove in pans and then heated up till the water content is extracted off. And then hopefully, if I've done my slides right, you get left with something that looks a bit like fudge here, kind of a bit like fudge. This is probably worth about between $20 and $30 to the guys that manufactured it. It's probably worth tens of thousands of dollars on the streets of whatever city it happens to end up with. And as this dries out, it'll go to that very familiar white color that you're probably used to seeing from the movies and probably from my original picture of Al Pacino with a load of cocaine sort of slapped all over his face. So eventually this will go to that rather traditional kind of white color as it dries out. And yeah, that's cocaine, and that's a very, very good high quality cocaine. What will happen with this is then it'll be taken away, and it'll be then cut to increase the profits of it. It's cut with lots and lots of things, lots of other drugs. It's also particularly cut with an anti-helminthic agent. Helminths are worms, and they're cut with an anti-helminthic agent called levamisole. And because levamisole, if you see the tablets crushed up, they look very similar to this. And we're starting to see the effects of that now, because it causes a kind of skin necrosis, which is we're seeing more and more, particularly in the United States, and is starting to emerge a little bit in this country as well. So this will be cut with, as I say, with lots and lots of other things to increase the kind of profit margin. But if taken like this, yeah, this is pretty much the super highway to your pleasure centers, really. This is this would be very, very high quality cocaine. So why have I gone from all of that to this ship? Well, this is a frigate called the Novara, and in 1856, this particular ship, which belonged to the Emperor Franz Joseph of the Austro-Hungarian Empire, and he sent this around the world to show how marvelous he was and how marvelous their empire was. And on board there were seven scientists. One of them was called Dr. Karl Scherzer, and he was friends with a guy called Dr. Frederick Wohler. Now, Wohler was probably the greatest chemist alive in the world at that time. He'd extracted urea, invented urea from ammonia. He created acetone. He was a brilliant chemist. And he asked his friend Karl Scherzer if he could bring him back a bale of coca leaves. So after this had been around the world, it turned up back in Austria with a 30-pound bale of coca leaves. And Wohler, who worked at the University of Göttingen, he gave it to his most promising student, who was a guy called Dr. Albert Niemann. And in 1860, Dr. Albert Niemann produced his PhD thesis, a very thin book, which was called A New Organic Base of Coca Leaves. And as was happening at the time, there were more discoveries of certain of other alkaloids. And if you think, there was the discovery of morphine, there was nicotine, there was strychnine, and so he called this cocainine. And if you join those two words together, you get cocaine. Okay, and if you like that, but he was the first guy who really extrapolated out of that what the alkaloid actually was. So he essentially did the process that I've just shown you in those earlier slides that got him to realize he actually produced cocaine in his own laboratory there. Interesting fact about Albert Niemann is he was 25 when he did that, and by the age 26 he was dead, not from cocaine poisoning, I hasten to add. Yeah, so that was the kind of the discovery really of cocaine, and it started to be produced. It was used as a topical anesthetic. It works very well as that. You started to be used in eye surgery, and then after a while, death started to emerge, and they started to realise the very complex pharmacology that was associated with cocaine. Now, one of the people who became very, very interested in this was a guy called Angelo Mariani. He was an Italian chemist, and he was very interested in Niemann's work, but for entirely different reasons. And Angelo Mariani went to Paris to kind of earn his fortune, and what he produced was this thing on the screen here, which is called Vin Mariani, or a type of wine coca. And what he did is essentially, broadly, he mixed alcohol and coca leaves in a bottle and produced this this particular substance here. It was particularly a favourite of the Pope, Pope Leo XIII, and others as well. Other writers and sort of literary figures of the time also kind of took to Vin Mariani. Now, the reason I've kind of put it up here with that, if you look to the left of this, is there's something very particular about combining cocaine or coca leaves, cocaine, and alcohol. One of the things is it's a great extraction method for getting the alkaloid out of the leaves. But also you produce, if you can look on there, that's cocaine in the center there. And the three things around it, not the one with the box around it, the other three things around it are the metabolites of cocaine. Okay, once you ingest cocaine, it's broken down principally in the liver and by other esterases in your plasma to these other products here, okay, which are then usually passed out in your urine. But what you can see there is if you combine alcohol, ETOH, with cocaine, you produce this product called cocaethylene. This is in itself a very, very, very potent, it's a very, very potent metabolite, but it's also has neurotoxic and cardiotoxic effects, and it lasts for much, much longer than the actual cocaine itself. So I think it's always a good starting point and to think about cocaine, that the quantity you take and how you take it and what you take it with are important in adjusting how your body kind of responds to it there. So yeah, what you see there is the product of coca leaves or cocaine and alcohol, which is cocaethylene. And I'll talk more on that later, but it's a very, very potent vasoconstrictor in its own right. So yeah, you can see why people kind of loved it, and you could see why he had a kind of really brilliant idea. Now, over in Atlanta, Georgia, in the States, there was another guy called John Pemberton who had a really brilliant idea of his own. He thought, oh, I'm going to make a fortune out of this as well. And he wanted to essentially rob the Vin Mariani idea for his own. But he was actually a Confederate soldier, and he was a morphine addict as well. And he was going to make a very similar product and sell it in in the United States. But unfortunately, history got ahead of him, and in 1885, Atlanta, which is where he lived, voted to ban alcohol. So what he was left with was a syrup, which consisted of two stimulants. One was coca leaves and the other was cola nuts. Okay, and what he found is that when he couldn't use alcohol, he couldn't mix it with alcohol, he decided he'd mix it with soda water. So what you got was soda water, coca leaves, and cola nuts. And I think you've probably all got the idea of what he invented. Yep, he invented Coca-Cola. Okay, so and there it is. And as he said, tired. Well, I suspect if you drank this version of Coca-Cola, it would certainly give you a pep up. That's for sure. Yeah, so that was Pemberton, who, you know, with the banning of alcohol, led to the creation of something very different, but went on to be obviously incredibly popular. I do need to stress now that that's not the recipe has changed somewhat in recent years. So if you're looking to go and get a 6-pack from Asda when you finish, probably it's probably not going to do you any good. So there you go. So yeah, just a bit of light kind of history for you there. So really, that's just the opening salvo. And what I'm going to talk to you now is a bit about the just to give you that, like I said, just to give you some background and some cultural context. We could do 3 hours on this quite easily, but I'm going to move on to the toxicity and chemistry of cocaine, and in particular the toxicity for us. This is age standardized mortality rates for selected substances in England. This is ONS data in 2018, and they produce one of these every 3 years. And so hopefully I'll get the next batch of data by the time some of you are passing through into your final year. But this is the 1993 to 2018 version of data, and essentially it gives you drugs really by the class that you'll recognize. So you see tramadol, you can see ecstasy, you can see codeine, amphetamines, antidepressants. So you see the sort of drugs that are associated with drug deaths. What's very interesting is you come 3 in from the left-hand side, so tramadol, codeine, cocaine. You can see that in 1995 there was a sort of an increase in cocaine use. You get to the sort of early to mid noughties, there's a bit of a drop off, and then around 2010, 11, there was a big upsurge in cocaine use, and this trend has actually continued. And so have so that's it in use. So a big upsurge in use, and obviously a big upsurge in the number of deaths. There was also an upsurge in the number of new psychoactives that came on the scene at the same time. There is some suggestion, and I may have talked to some of you before about this, that what was missing around this time was good quality ecstasy or good quality MDMA. And so people were looking for other stimulants. Just to say as well about cocaine is, as a product, it's brilliant, because as in terms of a product, its price has not changed roughly in inflationary terms for about 30 years. So in terms of the quality of the product, that kind of depends where you get it. But in terms of price stability, it's remained pretty consistent. Okay, so all these things are probably worth remembering when you think about cocaine in its cultural context. So yeah, what you can see there is a big kind of upsurge in the obviously the use and subsequent deaths from cocaine use. I can tell you that London is the capital. London is a very big cocaine user, and we could do that by measuring metabolites in sewage, in wastewater from sewage outlets. You can pick up those metabolites I showed earlier in wastewater, and it'll give you a picture of how much cocaine's being used. You can also find it downstream in fish. Okay, so fish will then take up the metabolites of cocaine, and you can do, if you do autopsy on fish, you can measure and assay the amount of these metabolites that are in fish. So yeah, the Thames itself is awash with the metabolites of cocaine. Why is it important? I think at the moment, I think because this was a very recent piece of news from about 3 weeks ago. There's a surge in fatalities amongst female cocaine users. In 2018, there were 637 deaths from cocaine. That was 117 women, 520 men. In 2019, that had gone up to 708, 148 women, 560 men. So drug deaths from cocaine, they're up for the 8th year running, 7.7 for men, 26% for women. And if you go back to 1993 data to 2002, the principal age for drug deaths was those aged 20 to 29. What we're seeing is that's changed. So if you come to the present day, 2019, 2020 drug deaths, the highest number of drug deaths were in the 40 to 49 age group, and that's new. So what we're seeing is an upsurge in cocaine use. That's probably these people who've got older using it, and the deaths that are going. There's a number of deaths that are obviously going up in those groups at the same time. So yeah, not a particularly brilliant picture. And probably the reason for this in the older age group, if you could call it that, is that cocaine is very, very toxic to the cardiovascular system. And I'll talk a bit more like that, about that in the next few slides. So really, what does cocaine do? Well, it's multifactorial. Its pharmacology is complex. It affects several organ systems at the same time, interacts with proteins, receptors, and ion channels. It's generally dose dependent, how that happens. And what you can see here is essentially a sort of block diagram of cocaine toxicity. And DAT, NET, and SERT are all different types of reuptake transmitter in your central nervous system. Okay, so DAT is a dopamine transporter, a NET is a norepinephrine or noradrenaline, and SERT is a serotonin reuptake transmitter. Now, dopamine gets into the pleasure centers, particularly your limbic system and the ventral tegmental area. Dopamine is concerned with emotion and evolved areas in areas that program us as a species to propagate things that are good for us. Okay, so that's why these are behaviors that can become addictive. So things like eating, sex. Okay, so those are the things that are species propagating, as opposed to things that are species non-propagating, like jumping off a cliff, for example. Okay, so that does not stimulate your limbic system, your emotions, well, not in a pleasurable way. And dopamine essentially signals pleasure. Okay, so dopamine signaling pleasure is species propagating. Okay, and you can get the same effect from a bar of decent chocolate, a hot bath, or a beer on a cold day. Cocaine at doses, like a line that we saw there, about 20 to 50 milligrams, occupies about 60 to 75% of one of those dopamine transporters. So what you can see here is, and I'll flesh this out as I go along, is cocaine is able to attach itself to these reuptake transporters and block them. And by blocking them, we increase the synaptic levels of dopamine, noradrenaline, and serotonin in the central nervous system. It also interacts with sigma and muscarinic receptors as well. Perhaps not so important. And what this leads to is overstimulation of those receptors, so increased stimulation of dopamine receptors, noradrenaline receptors, and serotonin receptors. And that all leads to cocaine toxicity, but that's only part of the story. There are several other areas as well that's particularly applicable, if you like, to cocaine toxicity. So I'll just try and walk you through this slide. I appreciate it's slightly busy, really, but what you can see on the right hand side is I've inserted this table here, which gives you the onset of action of of cocaine. Now, dissimilar to morphine, where the fastest way to mainline heroin to your system is to use it intravenously straight into a vein, and then it goes into your system. It's actually its faster, its fastest onset of action is when it's smoked. Okay, and you can just see that as a second one down there. Its onset of action in seconds is about 5 to 10. Crack cocaine is essentially the stuff I showed you, that that product, but then mixed with sodium bicarbonate, heated up, and then allowed to solidify and smoked in a pipe, and you get a much bigger hit from that. That's really rapid within seconds, but it wears off. As you can see, the faster the hit, it tends to then wear off very quickly. So you can see the difference there. Smoked about 5 to 10 seconds and lasts about 1 to 3 minutes to reach its peak effect, and then lasts for about 5 to 15 minutes of action. And you can see by rubbing it in your gums, you can prolong those effects. You get a much longer slope on it. And that's the problem with smoking cocaine, is you want to keep repeating it over and over again in kind of cocaine binges. Now, I talked about a number of transporters there, and what you can see on the side of here, if you look on the right hand side of this is the cocaine concentration in micromolars, and I'll sort of flesh out what that means as we go. But so you can see the increasing concentration up the right hand side of this diagram here, and what you see is very early on, quite low concentrations, you reach the point at which 50% of the serotonin transporter, the SERT that I mentioned, is occupied. Okay, so very low doses, serotonin transport is inhibited, and there's more serotonin in the synapse and interacting with those serotonergic receptors. As we get, as the dose goes up, and you can see that's just above what would be a mean serum level after 23 milligrams of intravenous cocaine, you can see we've now reached the point at which 50% of that DATs, that dopamine transporter, is occupied. So we're now starting to prevent the reuptake of dopamine and increase its synaptic concentrations. And as I say, this is the bit that stimulates reward, it's species propagating. And in studies of chimpanzees, a chimpanzee was prepared to hit a reward bar. So they put like a probe in the brain that gives a shot of cocaine straight into the limbic system, was prepared to hit the reward bar 13,000 times repeatedly for a single shot of cocaine. So that gives you some idea of the potency and the addictive quality, the mentally addictive quality of cocaine, 13,000 times. And when you compare that to other drugs, that's about 100 to 1,600 times, 100 to 1,600% more than any other drug that's been tested. So, you know, when tested on chimpanzees, they will eventually lose interest with ecstasy, heroin, and other drugs, but no, not with cocaine. They were prepared to continue to hit a bar up to 13,000 times repeatedly to get that reward of cocaine. Okay, sorry, I did that slight digression there. Go up a bit higher, and we've reached now 50% of noradrenaline or norepinephrine transports, and now we're starting to get to the real money shots here. These three are collectively are what's known as catecholamines, and catecholamine surge actually starts to, particularly noradrenaline, leads to increases in heart rate and also constriction of your blood vessels. It also causes an increase in metabolic activity, ATP turnover, which then increases the amount of heat that your body produces. So we start to see those kind of areas, those kind of toxicity sort of coming to the fore now. If you look just above there, you'll see the KD, that's the concentration of cocaine bound to essentially proteins in your blood. Once you reach the KD of alpha-1 acid glycoprotein, the cocaine's got nothing to bind to. So then you get an exponential rise, a big shift upwards in the concentration within your plasma. And that's when we start to get those really, really dangerous toxicities. You can see it's dose dependent, okay? And then we get to what I'm going to talk about in a little while, which is about the cardiovascular toxicity of cocaine, is that it's able to bind at these quite higher doses here with sodium channels, particularly sodium channels within your myocardium, and it's able to slow down those the passage of sodium ions across the cardiac membrane, and that slows depolarization. And I'll flesh that out with a couple of slides for you as we go. Okay, the minimum lethal dose we think is about 1.2 grams of intravenous cocaine, but it's at this point here where we get to about 90th percentile of death, cocaine levels for deaths. And then obviously you can keep going up. There's the highest cocaine level for a survivor in a series, and you can get to the highest post-mortem level here as you get to the top. So just to sort of give you an idea of how it enters the body, what that actually means, and then you can see as the concentration goes up, it starts to bind to these various sites, and obviously the toxicity then increases with that binding. So what does it really do? Well, lots and lots of things really. And as you can see here, you've got that cocaine blockage there at the top. You can see blocked neurotransmitter reuptake. This is noradrenaline and adrenaline. Okay, and what that means is there's more synaptic noradrenaline present, and this obviously increases your heart rate. It increases your blood pressure. 2 milligrams per kilo of cocaine produces an acute 10 to 25% elevation in mean arterial blood pressure. That's pretty big. Okay. You see an increase in heart rate, you increase in oxygen demand, but you also see that's through sort of beta adrenergic receptors, but you also see this alpha adrenergic effect where you get this very intense vasoconstriction at the same time. Remember that the metabolites that I talked about, particularly cocaine, last up from 4 to 7 hours, and it can still have effects on particularly the hemodynamics of the patient. And then what you can see along the bottom there is those slightly different effects from chronic cocaine use. So cardiomyopathies, accelerated atherosclerosis. So cocaine increases the amount of a vasoconstrictor called endothelin-1, okay, but simultaneously it also decreases something called nitric oxide synthase. So increases the production of decreases the production of nitric oxide, and nitric oxide is a vasodilator. Okay, so you get this again, this intense vasoconstriction. It also decreases the amount of TPA, tissue plasminogen activators. So it's prothrombotic, and that accelerates atherosclerosis, which you can see at the bottom of there. So it does have some pretty nasty long-term effects associated with its use as well. What I've tried to do is to put this into some sort of context of, as I know time is pushing here. And what you can see is cocaine at the center of this here. And we can see, does it cause pulmonary hypertension? Possibly, we're not sure yet. But what you can see is that increase in endothelin-1, reduced nitric oxide, and alpha stimulation. Number of effects there. The risk of aortic dissection is high, particularly in older users, although I have to say that the data suggests this is principally seen amongst users of crack cocaine rather than if you like, regular cocaine. Big risk of stroke, so the cause of thromboembolic events, not just cardiovascular, but also CNS, so stroke and intracerebral bleeding. And of course, across the other side there, you can see myocardial ischemia and infarction, and leading to cardiomyopathy, we've got that intense catecholamine surge, which I talked about, which again increases myocardial oxygen demand, again ischemia and infarction, and again cardiomyopathy. As I say, it increases the amount of TPA circulation in your blood vessels, and that creates a prothrombotic state. It also damages your vessel walls, and obviously because you get this intense vasoconstriction, you get impaired coronary and cerebral blood flow because of vasoconstriction. And just above that, you can see you get this deranged, what we call myocardial currents, which is the when you get that blockage of sodium currents. So you get impaired depolarization of the myocardial tissue. It also affects potassium efflux at the end of myocardial depolarization, and that leads to cardiac arrhythmias as well. So there's quite a lot of going on there, and I've tried to put it in this kind of block diagram here. I think basically you get the kind of idea that cocaine has a number of effects, particularly in the kind of acute sense. It's also, because it's able to increase dopamine concentrations within the brain, it can actually cause acute psychosis as well. So yeah, quite a lot going on there, and a lot for you to think about in terms of what are the risks. But I would say that suggesting that probably the risks are things like intracerebral events and cardiovascular events, so ischemia, infarction, and arrhythmias, particularly when we talk about the acute setting. And obviously these effects are made worsened by as you become more, as the toxicity increases, your pH drops, these effects are made much more prevalent. And of course, as I talked about, hypothermia as well, which affects the ability of enzymes in your body to work at their most optimal, in their most optimal state, as it were. So you get lots of kind of effects from that. So I did say that cocaine is a very good anesthetic. It's it's where the derivatives lidocaine and bupivacaine and norcocaine come from. So it's a very good anesthetic drug in its own right, and it's used. Lidocaine is used for nerve blocks and things like that. But of course, as the dose increases, what you can actually see here is that cocaine is able to block sodium channels within the myocardium, in those myocytes. And what that principally does is it slows depolarization here. So I put a kind of an ECG, and what you can actually see is that delayed depolarization there, represented as a widening QRS. So apologies a bit for this slide, but I did try and find a reasonably good one. And what you can see is, if you look at the QRS duration, for those of you who are maybe not so familiar, don't worry, this will all become meat and drink to you as you progress. But you can see the QRS duration there is 0.182 seconds. Well, that's out of range. We'd normally expect about 0.10 to 0.12. So the QRS is definitely widening on this. This is an acute cocaine intoxication. And you can also see what appears to be the start of a right bundle branch block as well. So in short, cocaine is able to affect sodium transport across the myocardium and lead to these kind of arrhythmogenic states that you see here. So what we've got is this widening QRS here. What's interesting as well is that can lead to a really quite nasty looking ECG like this one. I'm sure most of you will probably agree that that probably doesn't look right. And you see the rate has gone up now, and you can see the QRS duration is also going up 0.138 seconds now. So the QRS is getting much wider. And what you can also see, which is very, very particular to this type of arrhythmia and toxicity, is that all of you will learn the 10 rules of ECGs, and one of those rules of ECGs is they're always negative in AVR. So if you look towards the left of your screen, you'll see the AVR lead, which should always be negative. Well, you can see in this instance it isn't. It's got a very a very marked right axis, right upward shift. There's a right axis shift. And this is very particular to sodium channel blockade. There's a number of drugs that do this. Cocaine is one of them. Tricyclic antidepressants is another. Okay, so you can see that very, very particular positive deflection in AVR. And usually what we tend to say is if you get a deflection of greater than 3 millimeters, there's a very high likelihood that the patient will have a seizure. So it actually can be the height of that R wave in AVR can be used as an independent predictor of seizure activity. And that's something I'll be talking to particularly the third years and the second and first years as you progress through the program with me. So there you go, widening QRS and that positive R wave in AVR, big indicators of sodium channel blockade. So I realized that obviously I'm working through this at quite a pace, and I realized that time's against us. So just as well to point out that cocaine with its effects on endothelin and nitric oxide is an independent vasoconstrictor and can also cause vasospasm in its own right. This here is a particular ECG. For those of you who like ECGs, I'm not particularly fantastic on them, but there are people within the team who are very good at ECGs and really do like them. This is a particular type of ECG called Wellens syndrome, or in this instance, pseudo Wellens syndrome, which you get from certain drugs and particular cocaine use. And you can see A, B as it goes across, A, B, C in the bottom right, D in the, C in the bottom left, D in the bottom right there. And if you look at where the arrows are, what you can see is this developing ischemic injury, which produces particularly leads V2 and V3. You can see this evolving ischemic injury here, which results in this biphasic, this kind of biphasic pattern that you can see in the T wave. So I appreciate that it's not I've blown it up a little bit, but hopefully the arrows that are on there are starting to, so you can start to see this evolution. If you go from A to B, and then if you get to C, you can really start to see this very, very particular, this sort of, it starts as a kind of elevated takeoff in the ST segment and then a concave ST segment, that then becomes this negative T wave, and then finally a biphasic T wave inversion in V2 and V3. And this is an example. What you're seeing here is an example of, I'll just advance one more here. You can see this is the left anterior descending artery in the myocardium. And I've chosen this slide because you can see this is a cocaine patient from this ECG that was taken in. And what you can see is that really, well, hopefully you can see, is that really, really intense vasospasm of that artery that's causing this particular ECG problem. Now, in this case, the issue is not not rupture of an atheromatous plaque that's causing platelets to adhere and block the flow of blood down to the distal myocardium. Instead, this is just a very, very intense vasospasm, okay, caused by cocaine and the various effects of cocaine that I've talked about over the last half an hour or so. So hopefully you can see that there. So you can see that kind of really intense vasospasm of the left, coronary, left anterior descending coronary artery there, and that's causing that very, very particular ECG pattern, which is also known as a pseudo Wellens syndrome. So a couple of things there just to think about in the ECG. I think the take-home points in terms of toxicity, probably to prompt some questions, are tachycardia, increased metabolic use, so increased ATP turnover, increased production of heat, potential vasospasm, as you can see here, potential sodium channel blockade, okay, and that leads to potential ischemia, infarction, and possibly fatal arrhythmias at the same time. So I realised that I've spoken at you for a huge, for very quite a period of time. I didn't really get in. Perhaps maybe there was a number of other things that I'd have perhaps liked to have got in while I've been going. But at least I hope there's been something in there for everybody, and there's been a few areas of interest there. And obviously, you know, I am a member of the faculty here, so there are always sort of things you can come and talk to me about at a later date if you want. So with that in mind, I'll say I've just done just over an hour, so I'll say thanks very much indeed for your attentions, and I hope you've found the reasonably informative, and I'll be happy to take any questions that you might have over the next. Well, I'm prepared to stick around and answer questions, so hopefully some of you will be as well. Just some references to and some bibliography to finish, and with I don't think that's a particularly interesting slide, so I'll pop back to the one that we had just before then, which I think is probably a particularly potent visual illustration of the power of cocaine toxicity. So once again, thanks very much, everybody, and I'll probably just leave it there for now. Thank you.
Brilliant. Thank you so much, John. That was incredible. Not only a plethora of information on cocaine, but also really interesting to hear about its history and how it started. And I had no idea that that was how Coca-Cola started. So, you know, some very interesting facts in there as well. So I won't share my screen yet. I'll leave your ECG one there, okay, so that while we go through the questions, if anyone wants to have a look, they can keep looking at that. We do have quite a few questions. We'll go for about 15 minutes and we'll get through as many as we can. And I'll just pick some out from the chat. So earlier you mentioned about how the cocaine deaths in females was on the rise and how it was on the rise for the older population. You explained why the older population was affected, but I'm not sure if you touched on why female deaths were on the rise, and someone did pop that in the question. Is there any understanding on why that's the case?
Well, yeah, brilliant question, by the way. Yeah, we think that there are effects of sex hormones on cocaine concentrations, but I did have to spend a bit of time looking at this before I came this evening. Unfortunately, the only real data we've got comes from rat studies, and what we found is that male rats metabolize cocaine far more slowly than females do. So we know that females absorb and metabolize cocaine much more quickly. So particularly if you look at some of the metabolites which have toxicity in their own rights, and when it's taken with alcohol, those that toxicity also increases. So yeah, we think it's the effect of, or possibly from animal studies, it's the effects of sex hormones. So things like estrogen versus testosterone on the absorption and the peak plasma concentrations that we think are possibly are achieved more rapidly in females versus males. So hopefully that kind of might give us a clue.
Brilliant. Yeah, I think it absolutely. Yeah. Another very interesting question, actually. Is seizure activity likely to be due to neurotransmitter stimulation or vasospasm?
A bit of both is the short answer to that. Yes, particularly the increases in serotonin and noradrenaline. Also, the intense vasoconstriction, which reduces blood supply to very important areas of the brain. And if you look at some of the later slides that I put up, so it's probably a threefold. So you've got the increase in neurotransmitters, you've got a decrease in blood supply to the brain, and then you've got, well, if you take enough to get the cardiovascular effects, you then also get a drop in cardiac output, which then makes the plasma more acidic, and that plasma acidity and the reduced blood flow from the heart to the brain. All of those three things collectively increase the likelihood of seizure activity.
Brilliant, thank you. Someone's put, how important is the question, did you buy from your regular dealer when responding to a cocaine-related call?
Very important. I would suggest, without going into a great deal about cocaine dealers, I'm sure they're out and about there. I mean, street cocaine is it's cut with quite a bit, so its potency. I mean, its potency is pretty good. The prices remain pretty stable. But yeah, in terms of where you get your cocaine from, it's very, very important, because it's the quality of it and the quality per quantity that you get will obviously affect the way that your body responds to it. I think the best way of thinking about that is, if you think of the group of people most at risk from opioid deaths, so those former addicts who've been released from prison, so they go back to using their pre-sentenced amount of heroin, and that is obviously, whilst they've been in prison, and they've been abstainers, that then is a massive dose of heroin, and that puts them over the edge and into respiratory depression. Well, if you're getting a better quality product from a different dealer, then the chances are that your body will respond to that very, very differently and possibly more rapidly, and lead to increased toxicity. So yeah, I think where it's come from is very important.
So it's actually the potentially increased strength that is the danger, not necessarily what it's cut with.
Yeah, the potential increased concentration, or conversely, Oliver, the potential that it's been cut with other things. So it might have been cut with MDMA if they're feeling generous, but then if they're not, they might have cut it with something a bit more nasty, like, as I talked about, levamisole, which is an anti-helminthic drug, and that's not going to do you any particular favors. In fact, it causes blood vessel necrosis. So yeah, it's important. You might be getting a better concentration of product, or you might be getting something that's cut with some nasties.
Brilliant. Definitely remember that one in my history taking. We have a scenario here, which I think I was reading it and I thought it actually related quite well to finishing on your ECGs and how it affected the sodium channels. So it's quite long. I'll read it out. Recently, I attended a male in his 20s in cardiac arrest in a brothel. No evidence of any drugs or alcohol use on scene. However, the patient did have a history of cocaine abuse. The caller reported that the patient was very sweaty prior to collapsing and stopped breathing. On our arrival, the patient had been incontinent. I was in slow, wide, complex PEA, which shortly changed into P-wave asystole and then asystole an hour in. They've given a few OBS, so pupils 4, BM 4.9, temp 36. They were wondering how cocaine might have been related in that cardiac arrest, or if it potentially was. Does that sound like something that cocaine could have induced?
Yeah, absolutely. It does sound like something cocaine could induce. The age of the patient would be interesting on this one. But yeah, cardiac arrest from cocaine is a particularly you're at vastly increased risk, particularly at higher doses. So could you just give me the first bit of the case again? Sorry, I just missed.
Yeah, so attended male in 20s in cardiac arrest.
20s, yeah.
No evidence of drugs or alcohol, but they did have a history of cocaine abuse. Yeah. And the patient was sweaty prior to collapsing, stopped breathing, and then basically went into PA and then asystole.
Yeah, so yeah, cocaine can cause this, most definitely, for all the reasons that I've talked about, but in particular at higher doses or higher concentrations, its effect on two particular myocardial currents. That's the sodium current that I talked about, which increases decreases the depolarization and widens the QRS. But also there's cocaine at higher concentrations interferes with a particular potassium channel. Now, potassium channel potassium leaving the myocardium is associated with relaxation, what's called lusitropy or a lusitropic effect. So your myocardium is not able to relax fully, which is increases its energy demand. Or furthermore, when you block this particular potassium channels, you prolong the QT interval. Now, for those of you who know a bit more about the ECGs, that might mean a bit more, but you'll all get to understand this over the course of your time with us. But so you widen the QRS, but you can also prolong the QT interval. Now, if anybody knows that if you prolong the QT interval for long enough, you enter into a particular type of arrhythmia called toussaint de pointe, okay, which essentially means twisting of the points. And toussaint de pointe is very, very dangerous, okay, quickly, very, very quickly degenerates into VT, which then degenerates into VF and ultimately cardiac arrest. So, yeah, it's very, very possible. But to be honest, there are lots of things within this. It could be the thrombotic effect, it could be the vaso spasm effects, or it could be its ability to affect the QT interval or the depolarization gradients. So sorry, I've talked around it, but hopefully you've got something out of that, I think.
No, I think, yeah, brilliantly answered. We do actually have a follow-up question from one that we asked earlier. The question is seizure activity likely to be due to neurotransmitter stimulation or vasospasm? The follow-up question was diazepam or GTN first?
If they're in seizure activity, if they're in seizure, then it's diazepam first, absolutely. Mm-hmm. In terms of the treatment of cocaine toxicity, it's about doing everything to lower the metabolic state, so getting the patient relaxed, cooling the patient down. Then if they are like a GCS-15, but they are in a hyper excitable state, then the two things you want to use are nitroglycerin, okay, so GTN, and benzodiazepines. So in your case, diazepam. So the two principal drugs for early management are obviously relaxing the patient, cooling the patient, oxygen, and then it's nitroglycerin for chest pain and diazepam for CNS hyperexcitability. Okay, so if you find a patient, don't wait for them to seize, I think is what I'm saying. Don't wait for the patient to go into a seizure before giving diazepam. If they are, and you'll recognize if they're in a hyperexcitable state, then use diazepam. Diazepam will also prevent catecholamine outflow, so it has a beneficial effect when used concomitantly with GTN, with nitroglycerin. So hopefully that answers the question for chest pain. For chest pain, treat it as an ACS till proven otherwise. So if they've got persistent chest pain, it should be aspirin, GTN, oxygen, okay, and ring up your cath lab, okay, and have an ECG ready. If they're in a hyperexcitable state but no chest pain, then do use benzodiazepines, so GTN. And just a point to say to everybody on the on the benzodiazepines is benzodiazepines have no effect on cardiac channels. So they have no effect on sodium or potassium channels. So you can give them safely, is the point to say. They're not going to make the patient worse. Whereas you think about other anti-seizure medications like phenytoin and some of those that we'll talk about, they affect sodium channels. So in giving those, you can actually worsen the situation for the patient. So yeah, diazepam, benzodiazepines, very, very safe to be given to this particular patient group. Hopefully that answers the question.
Yeah, absolutely. I think it does. Well, I think that's all we've got time for questions. That's about 15 minutes there. So sorry we couldn't get through them all. But thank you so much, John, again. Fantastic talk as always. Thank you for supporting the society.
Thanks so much for having me.
As you continue to do. And yeah, already getting some comments there. So I'm just going to share my screen again now. Let's go back to our last point. So thank you everyone for coming this evening. I hope you enjoyed it. I know I certainly did. Our next talk, as you can see there on our screen, Endometriosis, 11th November at 7. So again, as always, please register to these events. There's the QR code. And when you come out of this webinar, it will give you the option to provide feedback. So please do, we really do value your feedback. And we love to hear what you think of our talks. And then it should also ask if you'd like a certificate. So if you want a CPD certificate for your records, I know third year specifically, we've got to start getting some, so super handy for us. Please fill that out. Feel free to get a certificate and add that to your portfolio. And yeah, thank you, John. Thank you everyone for attending, and enjoy the rest of your evenings, and we'll see you at our next event.
Thank you very much for having me. Thank you.